Hi.
Yes, hello, doc.
Hello. You are the medical student?
Yes. I'm the medical student, but I'm joining from my own device. The other will be joining by the class device, doc.
Alright. So, are they in or not?
Oh, sorry,
Because I
doc.
only see three participants only. It's me and you.
Yeah. I think the other still preparing for the device on the class, doc.
Alright. So anyone like will be hosting it, or should I just start?
Uh, I think we have to wait for the other, doc.
Okay. Alright.
Segera dipakai ini ya. Lagi 06. Ini pakai audio 06 juga.
Cek, satu, dua, cek.
Cek, cek tes. Cek tes 1 2 3. Halo tes, cek 1.
Cek, cek. Cek, tes, 1 2 3, cek.
Cek tes 1 2 3. Halo tes, cek 1 2.
Cek, tes, 1 2.
Tes, cek 1 2 3. Halo tes, cek 1.
Hello. Assalamualaikum and good afternoon. Are you all able to hear me?
I can, doc, but I think at the class still have a technical issue.
Hello, everyone.
Good afternoon, Dr. Subaida. Thank you for joining us for today. Today we are supposed to start at 1:20 p.m. Indonesian time, but now but the student has only arrived now. Yeah, we thank you for your time today, Dr. Subaida. My name is Dr. Debbie. I am the of this semester, and I am an anatomical pathologist, doctor. So your
Okay.
topic today will be very, very important for me and also for everybody else, for the student as well. Thank you, doctor,
Okay.
for joining us. Yeah, the students have already arrived now, and
Okay.
I think you can start if you want.
Okay, all right, sure. I will share my screen, yeah?
Thank you.
Can you all see this? Can you all see my slide?
Yes, doctor, we can see your slides, doctor.
Okay, thank you so much. All right. Thank you so much for the invitations. And Assalamualaikum warahmatullahi wabarakatuh and good afternoon, everyone. So now in Malaysia it's around 2:30 something, 2:35 exactly, 2:35 of PM. Right. So today I'm actually it's my pleasure actually to deliver the lecture on upper respiratory carcinoma. So my name is Dr. Zubaida, and I'm from IMU University, Malaysia. So basically, what the outline of this lecture, it will be covering some of the anatomical structures, but not too much of details, right? Because I think it's more like relevant on how to blend together anatomical structures, the physiological functions into the clinical correlations on few related diseases that has been outlined to me. So I will try to deliver it to you all. Basically, as we all know, upper respiratory tract diseases are common and they are clinically important because it involving the most important part of our organ, that is the respiratory tract itself. So the sites that we will be covering actually ranging from the nasal cavity, nasopharynx, and also larynx, and it will be continuous actually towards the trachea, the bronchus, and etc. So the conditions actually can range from infection, inflammations, benign tumors, and to even malignant tumors. So this is the nasal cavity, nasopharynx, and we will be covering part of the larynx also. What is nasal cavity? Nasal cavity is actually an olfactory and also a respiratory organ, right? And it consisting of the nasal skeleton, which houses the nasal cavity. And it has three divisions, and where does it started with is from the vestibules up to the posterior choanae before it's communicates into the nasopharynx. And it has three different division, which will be the vestibule, the olfactory region, and also the respiratory region. So the anatomy of the nose, we can actually overview it into the external part and also the internal part. For the external part, all of us know that is actually consisting of bony and also cartilaginous, and it will be covered, and it also has some musculature and skin covering the external nose. So for the surface anatomy, we have the roof, we have the bridge, dorsum, ala, and also apex. And as I mentioned just now, the skeletal components will be the bony and also the cartilaginous component. So what is more clinically relevant is that, for example, if we take the height of a nose is contributed by the framework of the nose. So for example, if any patient had some trauma that lead them to have septal hematoma, which is not addressed clinically, these will have disruptions of the septums, and later they will have septal necrosis and saddle nose deformity. So this is the importance of knowing back your anatomy, your physiology that is relevant that you can combine later to your clinical aspect. And another aspects that I want to cover actually, and I think you all have had the lectures on everything regarding the anatomy and physiology. So I just want to revisit again on these things, all right? So for example, we always talk about danger triangle of the face. What does it mean? It means that all the blood vessel supplies or anything, even from the outside of the axonal or the cavity here, it can freely move even up to your brain because it valvulus and it's the distributions of the vein, distribution of the blood vessels, all right? So, and that's why, a patient can start off with just a simple acne at this area and can even lead up to the complications of like cavernous sinus thrombosis and everything, especially for those who are immunocompromised. So by knowing these things, when we have patients later who have some infections over this area, you will be careful and we will follow up the patients accordingly. Now we move on to the internal nose, all right? So the internal nose, we have, as I mentioned, we have the vestibule of the nose, and then we have the nasal cavity proper. The nasal cavity proper are even actually subdivided into the lateral wall, where it will houses all the turbinates and everything. Then we have the septum, which will be dividing the nasal cavity into the right and also the left nostril, the floor, and also the roof. All right, and then the lining membrane will be according to the area that is covering. All right, for example, the olfactory will be covered by the olfactory epithelium, and the respiratory region will be covered by the respiratory epithelium. All right, and even for each particular of this area, they have their own blood supplies and also the lymphatic drainage. We move a little bit into the details of the nasal cavity. As the cross-sectional here, we can see the concave. Concave is the projecting out of the lateral wall of the nasal cavity. And the area down here is actually the meatus. So accordingly, the inferior meatus, middle meatus, and also the superior meatus. Is it relevant? It is relevant, yeah, because all the concave and also the meatus is actually, even though we have said part of the nasal cavity function is respiration, but it also serve the purpose of draining the nasal cavity, like for example, the paranasal sinuses, right? So for example, where the middle meatus is the most area that, like the frontal sinuses, the anterior ethmoidal, yeah, and also the maxillary sinus draining into the middle meatus, for example. And on top of the paranasal sinuses, we also have other draining into the nasal cavity. For example, nasal necromal duct that will drain into the inferior meatus. So what does it mean? It means that infection from the eye can actually lead down to the nose, or any pathology, even for example in the eye opening and everything, can actually being assessed by from through our nose. And behind the nose is actually the nasopharynx, where it houses the eustachian tube that connecting the middle ear into the nasopharynx, into the nasal cavity itself. And in the nasal cavity, we have like a rich vascular supply that serve the purpose of like temperature changes of the air that we inhale and everything, right? So it is actually receiving both from the internal carotid and also the external carotid. So I believe you must have learned about the Little's area where all the anastomosis of the vessels apply into the anterior, and we have the Woodrow flexus over the posterior part of the nasal cavity. And another aspect that I want to you all to understand is that part is the olfaction. Where does it houses? It's actually at the roof, most to superior part, right? And this carried out by the olfactory nerve. So what is the relevance of these things? Is will be if any, like for example, patient with base of skull fracture, we can have a CSF leak that coming out from the nose, which is called as rhinorrhea. Patient with polyps, for example, when it is like very big, all the I mean the smell and everything cannot be reaching up to the olfactory region area. Thus, hence the patients will be complaining about smell disturbances. That's why patients with polyp, for example, they will say they couldn't smell and everything. It's because of the receptors of the smell receptors is not being reached out by the smell, right? So now we move on to the paranasal sinuses. I believe you all know all the paranasal sinuses, and what is the functions of the paranasal sinuses on top of its draining? It also like lighten up our skull, and it also have a resonating our voices. The function of it. Okay, if you see the locations of the sinuses, right? So for example, we take as ethmoid sinuses, which is very nearby to the eye, right? So when a patient is having a sinusitis, for example, infections of the ethmoid sinus, because of the very close by related structures into the, and it can actually enter into the orbit, causing patients to have orbital cellulitis, like abscesses and everything. Polyps can actually extend into a certain area. For example, polyps from the in the nose can actually extend into the base of skull, hanging down to the oropharynx. Yeah, and the other function normally when a patient have anomaly in the nose and everything also, there are certain ways of purpose. The anatomical anomaly, I mean the anatomy of the nose can actually be used as an anatomical landmark when we are approaching for a surgery, for example, so that we know what is the safest thing and everything. So learning anatomy is not only about the disease, everything, and is very relevant, especially when we are going for any surgery or surgical procedures. Basically, now actually I have tried to summarize what are the physiology of the nose. It definitely is for the respiration, and air conditioning of the inspired air. That's why, for example, patient with tracheostomy, they are having difficulties in terms of a lot of secretion, cross secretion. They will have cough reflex and everything. Yeah. So in terms of air conditioning, it has served as the purpose of the filtration, temperature control, humidify the air so that when it reach our trachea and everything, it will be very comfortable, like temperature that reach our airway system. That the protections of the lower airway, where we have the mucus blanket layers, right? We have it serves also for the functions of Walker resonance. That's why when a patient is having, for example, a cleft palate, it will be hyper resonance voice. When a patient is having nasal blockage, for example, they will have hyponasal voice, right? And we also have like nasal reflexes, for example, sneezing, all right? And we also have olfaction function for the nose. So I just want to just touch a little bit on the air conditioning, for example, all right? So this is something that I realize, and I really feel this is wonderful things that we have the nose, you know. When we are in a heat environment, we want to on our aircon, right? So that we will feel a little bit cold. But if we are in a country that they are having cold climate, they will need another machine that is we call as a warmer for them to become warm, to for that to become warm. But our nose, we use the same nose. For example, when we are in Malaysia now, like the degrees like 36 something, and if you go to Mecca, for example, the temperature is 50 degree. And if we are in America, for example, during the winter season, it's like -10, for example, we are still using the same nose. So it can become our air condition, and it also become our warmer, so that whatever temperature of the air that reach our nose, it will be still 37 degree. It will be changed into the 37 degree and humidified almost 100% before it reach our trachea and all the rest of the balance of the respiratory systems. Is so wonderful, so wonderful. And we have a mucociliary clearance system, you know, that works out continuously for to like a blank mucous blanket posterior, for example. You know, when patient is having problem, for example, patient with cystic fibrosis, they are having this mucus secretion problem, so they will lead to pathology. All right, I have discussed about the olfactions, and I also have discussed a little bit on the voice resonance just now. So now we move on to nasopharynx. This is the nasopharynx. So when we understand the nasopharynx, for example, the anatomy later, when we are discussing about nasopharyngeal carcinoma, for example, then we will understand better on what will be the patient's symptoms, for example, yeah. So after the nasal cavity, throughout this posterior choana, we are going to the nasopharynx. So it's extending from the base of skull to the soft palate, right? And it houses, we have here adenoid tissue, for example, here at the posterior part, and all these this one, we have tubal tonsil and everything. All these are part of the Weldeyer ring, or the defense systems in the head and neck area. We also have here one important component, which is the eustachian tube opening, which serve the purpose of ventilations of the middle ear. And another structure that we have here, the cleft here behind the torus tuberous, it houses the fossa of Rosenmuller. So this is the most common site for nasopharyngeal carcinoma. So basically, the nasopharynx physiology is for the air passage, pressure equalizations into the middle ear, and it's parts of the immunological defense systems in the head and neck area. Now I move on to the nasal and nasopharynx examination tool, all right? So this is what in Malaysia setup, right? This is something that is available, right? The figure 91 is something available in a normal clinic, in a normal district hospital, and some for example setup. But the lower part, the figure 100, is something rigid scope, is very specialized, used by ENT surgeon normally, or ENT specialist normally, all right? So now I want you all to understand, all right? When you become a doctor later, this is the figure, the things in figure 99. For example, the B is the tunicum nasal speculum, is something that is available for you, and you can use that to do your examinations of your patients, all right? Now, how does it look like? ARS means anterior rhinoscope, right? So when you do a normal anterior rhinoscopes, you will be able to see the septum, the floor, the inferior turbinates, and the maximum that you will be able to see is actually will be the middle turbinate, right? Not more than that. You won't be able to see the roof. You won't be able to see the superior turbinate, for example, and you can't even see the nasopharynx or the posterior choana, for example, right? That will this, so this picture up here is normal one, And the lower part also is showing normal anatomical structures that you can see from your anterior rhinoscopic. So always understand this. You have to know what is normal so that you will be able to detect what is abnormal. So for example, when you know this picture on the left is normal, so you will know that this one is abnormal. Why? Because it's very swollen here, right? This is the inferior turbinate hypertrophy. All right, the lower part is showing the inferior turbinate hypertrophy, but almost touching already with the septum. Now we move on to little bit on the laryngeal mirror examination. This is for the larynx, yeah. This is for larynx. These are the structures that we use for the larynx. Normally, at least we have this mirror, all right, this mirror. And then I want you all to see the difference of the mirror that we use for the posterior rhinoscope. It will be angulated here. All right, and this one will be inserted through the oral cavity of the patient so that we can at least still try to see the nasopharynx of the patients, yeah. But for laryngeal examination mirror, we are using this straight mirror, all right. So this this one is indirect laryngeal mirror examination. Some of the setup in Malaysia, for example, we have this mirror and you can go to examine the patient's larynx when you have another lighting, and you can straight away do the examinations, all right? Meanwhile, on the right side of the picture, this is a flexible scope. When we insert through the nose of the patients up to the larynx of the patients, right? But this one is also normally be used by specialized setup, for example, ENT clinics, in operation theaters, in emergency department, all right? So what you all need to become later, maybe I think in a normal setup, a generalist doctor will be able to examine at least using the indirect laryngeal mirror. So this is how a larynx will be look like, all right? So for example, you need to know the anatomy. Again, I emphasizing you need to know what is normal so that if there is something abnormal, you will be able to detect it and to understand about it. All right. So for example, this is the true chords, and right, and then we can see here it's actually the false chord. This is the posterior commissure. This will be the anterior commissure, where the two parts of the vocal cord will be meeting. All right. This is a very nice picture because it's taken, I think, in the operation theater. So you can see everything quite obvious, yeah. But what I want to share with you is that when we are doing an IDL laryngeal mirror in a normal office setup, clinic setup, all right, there are certain limitations. One is the visualizations uh, of the anatomical structures in the larynx itself, right? So this is what we call as hidden area of the IDL laryngeal mirrors. For example, in between the the true chords and the false chord is a lateral cleft we call as ventricles. All right, this is something you can't see just based on your mirror image, yeah. Part of the apex of the piriform fossa, for example, you won't be able to visualize it. All right, so it means, what does it means? It means that sometimes patients can come to you with a complaint of hoarseness, and you do your IDL laryngeal mirror examination. Maybe there is a tumor, but maybe the tumor is located really anterior part here at the anterior commissure, which is not seen, or sometimes is the hidden area in the laryngeal mirror. So what can happen is that maybe you will miss it. So by knowing your limitation with whatever examinations that you know, it will actually help you in terms of on how you want to manage your patients. Okay, now I move on to the diseases itself. Yeah. So now the first thing that I want to cover is that the nasal polyps. All right. So what is the definitions of a nasal polyps? It's actually non-neoplastic, edematous nasal or sinal mucosa. So how does it appear? It's a benign, edematous, soft, painless, semi-translucent masses of the nasal or paranasal sinus mucosa. Most of the polyps, they are multiple, and it usually arises from the lateral wall of the nose, which is the middle meatus. The etiology is really complex, not well understood, yeah, but some attributed it is like chronic inflammations that leads to mucosal edema. Then there will be collections of the extracellular fluids that leads to a polyps formations, and then the polyps become bigger, sessile, and it will be pedunculated later. Right. So because of the basis is inflammation, there will be also inflammatory mediators found in the polyps. So we move on to epidemiology. It's more common in adults, especially in males, and the peak incidence is 30 to 50 years old. So as I say, it's very diseases associated with the polyps. For example, patient with chronic rhinosinusitis. For patient with asthma, 7% of them will have polyps, especially those who have aspirin sensitive asthma. Patient with aspirin intolerance, like 40%. Patient with cystic fibrosis, that will they have secretion the mucus problem. Patient with allergic fungal sinusitis, almost all of them will have polyps, and patient will have catagonous syndromes, or we will have the cilia problem. What will be the symptoms? Most of them will come with nasal obstruction. Mostly it's bilateral and it's progressive. Patient will initially maybe have hyposmia, later they can progress into anosmia. Patient, because of the secretion being blocked from the sinuses and everything, patient can have headache or facial pressure, and they can even come to us with associated sinusitis infection problem. Patient can have nasal discharge, which is mucus or mucopurulent. Patient can also, that is will be anteriorly and posteriorly. When it goes, the patient will complain of postnasal drip, yeah, and nasal speech, as I mentioned just now, because of the blocked nose, and sometimes the mass itself can be protruding. So if you do an examination, how does it look like? It is glistening, peel grape-like mass. You know, when you eat grape, if you try to peel it, it will be looking like this color, yeah. And it's commonly arising for the middle meatus. Normally it's multiple, bilateral, and it's pale, painless to touch, and it do not bleed on touch, and it will be mobile on probe. So these are the features that you will like to look into when you see a patient with polyps. What does the features of the polyps will actually tell you so many stories. That is for the multiple one. Now we move on to unilateral polyps. Most common one is the enterochoanal polyp, right? So it's coming from the enterochoana, right? So, and I want to mention about this also. A simple polyps in a child need to be really worked up before you even do some invasive procedure, or some simple, we consider as simple if in adult biopsy, taking biopsy for example, because sometimes it can be mistaken for glioma or meningoencephalocele or even encephalocele. So do not biopsy until you confirm first what is the polyps lesion coming from. So hereby, I have actually given some of the differences between ethmoidal polyps, which is the most common one, and another one is the enterochoanal polyps. All right. For ethmoidal polyps, it is in adult, whereas comparing to the children and adolescent, mostly it's because of allergy, whereas enterochoanal is because of infection. It's multiple. The enterochoanal polyp will be single, mass, and trilobed. Yeah. and it will be unilateral. Okay, this is very unique of enterocorneal polyp, and it's from ethmoidal labyrinths, and mucous membrane on the maxillary sinus will be the area that is coming from. And normally it can be seen on the ARS anterior rhinoscopy for ethmoidal polyps, whereas because of the location itself is going to posteriorly, mostly can be seen only by posterior rhinoscope. And for ethmoidal polyp, recurrence is common. However, for enterocorneal polyp, recurrence is uncommon if complete removal is done for the patients. All right. So for diagnosis, normally we will refer the patients to ENT. We will proceed with nasal endoscopy. Even though sometimes we see more features of benign and everything, sometimes we do take biopsy, or sometimes biopsy and send for HPE to confirm our diagnosis. We can also do a CT scans to see the extent of the polyps, right? To like plan our approaches and everything, and even to discuss with the patients complications of surgery if we are going for surgery. Management wise, okay, it is a taboo, every patient with polyps needs to go for a operation. It's not, right? So that's also partly beauty of being an ENT surgeon, right? Not everything we will go like surgeon, we do surgery, everything. It's not like purely like internal medicine, we purely do like using medicine and everything. It's a balance almost. That is from my point of view, right? Okay, so for example, we can try even medical polypectomy, right? So for example, like lower grade of polyps, sometimes we can see some total cure just by giving medical polypectomy. It means combinations of few medications or drugs that we give to the patients that can actually shrink the polyps, all right? Sometimes failure of this medical polypectomy, then maybe we can go for operation, which is the functional endoscopic sinus surgery, all right? So it is our part to actually explain this to the patient, because otherwise most of the patients, they will refer to Professor Google, and then they will say everything is like going for operation when it's not. All right. So this is some of the points to remember for you all. All right. Any red, fleshy, friable, granular surface, especially in elderly, you need to think of malignancy until proven otherwise. All right. And a simple nasal polyps also may masquerade malignancy, especially in individuals older than 40 years old. So normally what we will do is that all polyps should be subjected to histology. Epistaxis, when a patient is having epistaxis and orbital symptoms associated with the polyps, this also should raise a red flag to you, and really need to work out, is this really a polyps or is something else? Now we move on to a juvenile nasal pharyngeal angiofibroma. In Malaysia, we call it as JNA, right? So it's actually a benign but locally aggressive vascular tumor. All right, this is a vascular tumor, and it's arise from posterolateral wall of the nasopharynx near the sphenopalatine foramen. And for the epidemiology, it occurs almost exclusively in adolescent males, because they attributed it into androgen dependent tumor. That's why they said if you diagnose a female with JNA, genetic testing is needed for them. So for juvenile nasal pharyngioma, what will be the symptoms? As we said, it's a vasculitis. Patient will have profuse recurrent epistaxis. All right, most it will be unilateral, but it can be bilateral also because of the continuity of the nasal cavity. All right, patient will have progressive nasal obstructions, usually unilateral, but it can become bilateral later. Patient can have nasal discharge, and even this nasal discharge also normally often blood stained nasal discharge. If it is advanced, is the pressure effects and the tumor is like really expanding, patient can even have facial swelling or deformity. All right, and because of it depends on the extent of the tumor itself, patient can sometimes have headache, anosmia, and even hearing loss because of the eustachian tube blockage. So it really depends on the extent of the tumor itself. Now we move on to how does it looks like when you are doing examinations. So it will be a unilateral, vascularized mass or polyps. So if the patient's clinical feature fits, example, is a male, is a adolescent age, and it's more towards complaining of like epistaxis and everything, and the minute you see a tumor that is like very vascularized and everything, you must think of JNA until proven otherwise. All right. So it will be mostly is posteriorly located. All right. Posteriorly located, and sometimes it can be hanging down to the nasopharynx, and it can even pushing to the septum, like this one, pushing to the septum because of the mass effect. So any red mass in the nasopharynx that bleeds easily, you must think of JNA first. All right. For diagnosis, always remember any polyps that is vascularized and everything, a biopsy is contraindicated, right? Because of high risk of bleeding. Patient can bleed till death. All right. So this is very important for us to understand this, right? Because more normally when we do biopsy, we will just do in the clinic setup, so there won't be like a setup that can actually help the patient if anything happens, right? Also, normally what we will do is that CT scan is contrast enhanced. It will be like quite sufficient actually to be our first imaging, so that we can see, normally we can see hypervascular mass, right? From the nasopharynx, like for example here, there is a posterior nasopharynx mass, vascularized, hypervascularized mass, and there is also erosion of the pterygoid plate. All right, we can't see already, so the pterygoid plate, everything is already eroded. Sometimes we need to do also MRI, right? Because we want to define the soft tissue and also the intracranial extensions, we might do an MRI. So the choice of investigation, normally the first one will be CT scan, but the subsequent investigation will really depends on what we want to do. So for example, we can do angiography, so that we can see the vascularized, and we can at the same setting also we can plan for an embolizations, and we can even do an embolizations at the same setting. So normally for the management, it will be preoperative embolization so that we can actually really secure the bleeding amount of bleeding later during surgery, and later we can actually remove the tumor itself by the surgery. Next, I'm going to nasopharyngeal carcinoma, NPC, right? This one is a malignant epithelial tumor arising from the nasopharyngeal mucosa, and as I mentioned before this, most commonly from the fossa of Rosenmuller, which is the lateral part of the nasopharynx or the cleft behind the torus tuberous, right? And it is characterized by early lymphatic spread and association with EBV virus infection. For the epidemiology, it's high incident in southern China, Southeast Asia, including Malaysia and also North Africa. So the males predominate like 2 to 3 into 1, and commonly found among the Chinese Cantonese ethnicity in Malaysia. We have very high nasopharyngeal carcinoma incidence in Bidayo, one of the indigenous people of Sarawak, one of the states in Malaysia. And in Indonesia, the one that I found is that NPC is one of the third country with the highest mortality from nasopharyngeal carcinoma. The etiology is not known, but the risk factors will be genetic link, like the HLA-A2, viral EBV, environmental factors, for example, diet rich in salted fish, nitrosamine, smoking, air pollution, and everything. Family history, which is quite relevant also for nasopharyngeal carcinoma. So again, what will be the symptoms of nasopharyngeal carcinoma? As I mentioned, if you understand the anatomy, you will be understanding much of the symptoms that the patients will come to you. As I mentioned just now, it is a very a place which is rich with lymphoid tissues and everything, right? So when they see in order of frequency, most of the patients will come with neck lump, and normally at level 5, level posterior triangular, all right? And as you can see, this is the fossa of rosemola, this is the torus tuberous. And when the mass is there and it's pushing, it can push the eustachian tube. What will happen is that patient can have unilateral middle ear effusion because of the blockage of the eustachian tube. So subsequently, patient can have hearing loss, conductive type of hearing loss. Patient can also present to us with tinnitus, unilateral tinnitus. So as you can see, the symptoms will be sometimes very subtle, unilateral tinnitus, It's not like profuse bleeding, malignancy need to be pain, malignancy need to be bleeding, nothing. Not that kind of things also, right? So you need to really be aware of this kind of symptoms so that you can actually treat the patients, pick up the patients very fast. Patient can have nasal blockage, right? Because it's continuous with the nasal cavity, and mostly also will be like unilateral rather than bilateral. But when it's become more progress, it can become bilateral, and because of it is extended from the roof base of skull here to the soft palate, so it can actually goes into the cranium very fast, very easily. All right, and the most common cranial nerve involved will be cranial nerve 6, right? So how does patient cranial nerve 6 is for lateral rectus, so patient will have squint, but how do they complain to us? They will be diplopia. So now we move on to the sign. As I mentioned, lymphadenopathy, 60 to 90% of the patient will have lymphadenopathy, right? Mostly it's the posterior triangle. Patient can have unilateral middle ear effusions or serous otitis media. Patient can have cranial nerve palsy, for example, the 6th cranial nerve palsy, right? So anything, presence of unilateral middle ear effusions or serous otitis media in an adult should raise suspicions of nasopharyngeal carcinoma. So nowadays in Malaysia, we already have the guidelines for nasopharyngeal carcinoma. So this is part of the things that we attribute to all the GPs, all the doctors in klinik kesihatan. Klinik kesihatan is our primary care in Malaysia. So we always advocate this. Any patients that you have with unilateral middle effusion should raise a suspicion of nasopharyngeal carcinoma. All right. Why I am emphasizing this is that in a primary care setup, ones need to be suspicious, hence refer to ENT. As I mentioned, the anterior rhinoscopy won't be able giving you the ability to find whether there is any mass in the FOR. Even the posterior rhinoscopy rarely can give you the idea what is happening in the nasopharynx itself. Normally, the patients need to be referred to us, the ENT, and then we will do the nasopharyngoscopy, and then we will do take biopsy, tissue biopsy, and then send, and then we'll confirm the diagnosis. All right. So sometimes most of the patient we will do CT scan first, unless we want to see soft tissue extension, we will order MRI. Some we will also do EBV serology for screening purposes, and even to follow up later whether the titer is coming down or not. The treatment is chemoradiotherapy. Okay. One thing about nasopharyngeal carcinoma is something very treatable, right? The prognosis is also quite good. So that's why it's very important if we are able to pick up the patients as soon as possible at early stage, they have a higher chance of a better prognosis. But having said that, at any stage the patients come to us, there's still hope when a patient is diagnosed with nasopharyngeal carcinoma. Something quite workable disease for nasopharyngeal carcinoma. So that's the important of it, so that we can still give hopes to our patient so that they will still follow through our management. Yeah, here I have outlined the differences between JNA and also NPC. So basically, we know JNA is a benign tumor, whereas NPC is a malignant tumor. JNA is quite a rare tumor, but NPC is quite common. It affects extreme age of extreme, quite a little bit of extreme. I will say that this part is adolescent for the JNA, and for the NPC it will be like 50 to 60 years old. But having said that, also any age actually nowadays we are seeing many patients like even 40 years old, and even we had the youngest patient, I think 11 years old, of patient we diagnosed with NPC. All right. For JNA, it's a testosterone hormone dependent. Meanwhile, for NPC, we have discussed what are the etiological or the risk factors for patients to develop NPC. All right. JNA is direct extension to adjacent areas, for example, the infratemporal fossa, and for the NPC, because of the malignancy, it has the feature of erosion. All right, so any abnormality that it will give us is because of the erosion capability of that tumor. All right. JNA, there will be no lymphatic spread because it's something benign, but NPC, most common presentation is lymph nodes spread. Patient with NPC will have patient with JNA will present to us with massive epistaxis, but patient with NPC, normally what they have is bloodstained saliva, nasal discharge, bloodstained nasal discharge, and everything. Rarely they will become like with diffuse epistaxis unless the tumor has already invaded the blood vessels or the blood supply. For Gen A, we can do CT scan but no biopsy. But for NPC, we can do a CT scan with biopsy for us to diagnose the patient. I hope I can move to laryngeal carcinoma. Yeah? So this is part of the respiratory system that we have discussed just now. So for laryngeal carcinoma, it is actually also a malignant epithelial tumor arising from the laryngeal mucosa, and is commonly a squamous cell carcinoma. So the larynx itself, we actually divide it into supraglottic, the glottic, which is also called as true vocal cords, and we also have subglottic, because different sides of the larynx will present to us with different features, clinical features, and management also sometimes will be differ. So what is the process for laryngeal carcinoma? So any chronic exposure to carcinogens, most common, the strongest link is smoking. However, if a patient smoke plus alcohol consumption, it becomes synergistic, like 15 times more. If I want to make you understand what does it means by synergistic, it means in mathematics we learn that 2 plus 2 is equivalent to 4, right? But here 2 plus 2 is equivalent to 15. That's the meaning of synergistic, all right? So it's as attributed with HPV, in contrast with nasopharyngeal carcinoma is with the EBV. Exposure to asbestos, wood dust and everything, and previous radiation, for example, patient who had laryngeal papilloma, they've been radiated for that treatment. These also can give them risk factors for developing carcinoma later. Predominantly, it affects males, 5 to 10 to 1. The peak incidence is 50 to 70, and glottic carcinoma from the supraglottic and also subglottic. Glottic carcinoma is the most common type. So the symptoms will be hoarseness, Hoarseness will be early and persistent. This is the hallmark sign, okay? And I want you to also understand this. Vocal cord is something very minor or subtle abnormalities happen there. It will be giving us the signal by a patient or producing abnormality in their voice. Abnormality in their voice, yeah. So patients can have dysphagia or odinophagia. All right. If you all understand the anatomy, the larynx is in the anterior part, the pharynx and the esophagus and everything is at the posterior part. So they are very nearby, no walls, nothing that's separating them. All right. So patient with laryngeal problem can give rise to swallowing problem. Patient with swallowing or the GI tract also can give rise to laryngeal symptoms. All right. This one we need to understand. So patient can have painful swallowing, foreign body sensation. Yeah, patient can have stridor when it's really obstructing the airways. Patient can have cough or hemoptysis. Yeah, patient can also have neck mass due to nodal metastasis. Here, actually, I have tried to um, give a points for each of the sites depending of the sites. Yeah, for supraglottic, if you see the anatomy, it's wide area, right? It's wide area. So normally it will be silence, right? Because they have the space to grow before they really give symptoms to the patients, right? Patient can have throat pain, because of the distributions of the nerve, referred ear pain, and then however, when it progress from the supraglottic, when it comes down here, patient will have hoarseness. So if a patient is having a supraglottic mass or supraglottic malignancies, the moment patient have hoarseness, we can figure out maybe it's already quite extensive involving to the glottic area also. Patient can have halitosis, patient can have significant loss of weight, all right? And just a little bit of sharing here. Normally, when we say patient with malignancy, we always say about consistent symptom, loss of weight, loss of appetite. But it's not true when a patient is having a head and neck malignancy. Not all patients with head and neck malignancy will have this loss of weight, loss of appetite. If you refer back to my earlier lectures on nasopharyngeal carcinoma, for example, I didn't mention that as the main thing, right? So that's why when a patient does not have consistent symptom, it does not mean that they don't have the malignancy. This is something very peculiar to the head and neck malignancy. Sometimes they don't even have that. But for patient with like supraglottic, very extensive, patient with pharyngeal carcinoma, oropharyngeal carcinoma, oral cavity carcinoma, yes, they can have this significant loss of weight and loss of appetite features. Yeah. And this supraglottic area, they have rich lymph nodes supply, right? So that's why lymph nodes involved occur at a very early stage, right? And for glottic cancer, which is the most common site of malignancy that occurs, it is quite early, can be detected, as I said just now. When something very subtle also happens, it can lead to changes in the voice that lead the patients can come to medical attention, right? So early will be hoarseness, but later they will have stridor because the more they keep the tumors and everything, when the airway become more obstructed, the patients will present with stridor, right? And for glottic cancer, again also, it's not a must to have a lymph nodes in a cancer, especially for example in nasal cavity, for example, nasal cancer, we rarely see any patient with lymph nodes. And for this glottic cancer, never seen a lymph node because it's it's parts of lymph nodes. Lymphatic channel. However, When there is presence of lymph nodes, it means it's already extensive tumor, all right? Maybe it had gone to the supraglottic, or maybe it has goes down to the subglottic, or maybe now it become transglottic cancer. So that's why the patient now is having a lymph nodes enlargement. Meanwhile, for subglottic, you see is already now in the airway. So how the patient will present? Most of them will be because of the airway caliber is now smaller. Patient will now present early stage will be stridor. But later, if it is involving to the glottic, patient can have hoarseness. So for these kind of patients, hoarseness will become a late presentations. And this one also they will have a lot of lymph nodes involvement. Yeah? So supraglottic and subglottic, they will have lymph nodes involvement comparing to the glottic CA. So what will be the signs? Some of them will come with voice changes, some of them will come with stridor first, some of them will come with respiratory distress and everything. All right. And as a medical student also, it's very important for you to recognize what does it call when a person is having stertor. How does it sound? Where is the obstructions? You have to understand that because different noisy breathing give rise to different locations and give rise to different types of management. All right. So what is stertor? How does stridor? Stridor also we can actually divide into three parts. The inspiratory stridor, the expiratory stridor, the bifixed stridor. These will give you hint where is the different locations of the abnormality. Yeah. And how does wheezing sounds like? All right. So all these things you have to know and you have to try to identify. All right. So this is like, for example, this is a indirect laryngeal mirror examination. All right. You can see maybe there is some irregular ulcerator or exophytic mass, everything. All right. So as I mentioned just now, there are hidden area of the larynx, right? So no mass is not equivalent to no lesion for patient with abnormality in the larynx area, right? So uh, sometimes it just means that it's the limitations of your instruments. Yeah, maybe you need to really work up further accordingly for the patients. Yeah, patient can also might be having vocal cord immobility or palsy. Maybe you can see also part of the airway narrowing. Yeah, and we can expect some neck mass, for example, in supraglottic tumor especially, right? So basically, any patient, especially patient with cancer age group or high risk group, for example, smoker or smoker plus alcohol consumption or family history, having persistent or gradual hoarseness for more than 2 to 3 weeks, the patient must have a proper laryngeal examination. So normally, again, we will do a laryngoscopy and biopsy, but this one, we will see the mass lesion first. But for biopsy, we will do it under general anesthesia. I mean, in the operation theater, we cannot be just taking it in the office setting, yeah. And then we can do CT scan or MRI to evaluate the extent and cartilage invasion. We can also do a chest X-ray or CT scan to rule out metastasis. The treatment really depends on the stage. So that's why it's also important for us to have a early diagnosis so that we can give rise the patients to a proper management, a faster management. All right. For early stage, we can go around by, like, for example, giving radiotherapy alone, or we can even do endoscopic laser excision. So it means a single stage, yeah. So it means we can still try to preserve the voice. For example, if a patient is a teacher, that patient is a teacher, can we imagine what kind of magnitude he will have if we are removing the voice box or the larynx for the patients, right? So that's why we try. There are also arm of treatment where we can be try to preserve the voice. However, for those who have advanced stage like T3 or T4, normally we should go for partial or even total laryngectomy with neck dissections and with or without chemoradiotherapy. It really depends on the type, the extent of the tumors and everything, right? But in a blanket, we will say that advanced stage they will have to have like combined things, and now we can't preserve the voice anymore. So now the voice rehabilitations come in, right? We have like multiple choices of voice rehabilitation, but the moment a patient is diagnosed with cancer, normally they lose their spirit, their motivation, something. And you really have to be motivated. For example, if you want to use the tracheoesophageal speech, it's like speaking using your esophagus. They really need to learn and to practice. And if they are not interested to learn, with that age and everything, we can provide them with electrolarynx, yeah. But the limitation with electrolarynx is that it's something machine, right? Machine, so the quality of the voice will be like robotic, really robotic, yeah. Even though they say it now it's more advanced machines that they have and everything, but still, some of the patients not preferring it because of the quality of the voice. Hence, from my limited experience, most of the patients sometimes they just keep remain silent for throughout of their lifetime. So this is where it's really important to really prepare the patient from the beginning, and multi-departmental work, and together with the family members and everything, so that we can there are a lot of options actually. The patients no need to be like really silent forever for their life, but there are options. Yeah, we have valve, we have prosthesis nowadays and everything. Okay, so I think basically here I'm trying to summarize uh, few of the diseases that we have discussed today: the nasal polyps, the ANJ, NPC, and also for the laryngeal carcinoma. As you can see, both nasal polyps and GNA, they are benign tumors, while NPC and laryngeal carcinoma, they are malignant tumors. The age, you can see every disease, they have like specific age that is more common, right? But it can still occur beyond or outside the expected age of the symptoms, yeah. For nasal polyps, the key symptoms will be nasal block. For ANJ, it will be epistaxis. For nasopharyngeal carcinoma, the most common one is the neck clump. For laryngeal carcinoma, as the most common is clotic CA, it will be hoarseness. Right, for the nasal polyps, it will the site is from nasal cavity, ANJ, for nasopharynx, both ANJ and also NPC for nasopharynx, and for laryngeal carcinoma, as the name mentioned, is from the larynx. All right, so different types of these diseases, also the different type of treatment, and for malignancy, it really depends on the stage of the disease itself. So as summary, I think early detections improves outcome, and anatomy and also physiology understanding sometimes will aid you in terms of early diagnosis and how you want to manage your patients. Benign lesions may mimic malignancies, and always correlate symptoms with lesion size. So, and always think about something more common first rather than just getting out of order things. All right. So these are few of my references. I think that's all for my presentation. Anything you all want to ask?
Thank you so much, Dr. Subaida, for your lecture today. Thank you so much for covering the anatomy and the basics as well. It's really helpful for the student to learn and refresh the basic things first before heading to the carcinoma and the cancer cancer topics, of course. Yeah, I would ask the student if they have any questions for you. We can start. Anyone want to ask anything to Dr. Subaida? Yeah, I want to ask something for Dr. Subaida.
Yes.
Yeah, so as a pathologist, Dr. Subaida, I want to ask if there is any difference in epidemiology in nasopharyngeal cancer in Indonesia and Malaysia. If in Indonesia, I see a lot of nasopharyngeal cancer, especially in the in all ages. But in Malaysia, is there any like specific age group or specific gender or specific ethnicity like that, Doctor?
Yeah. As I said just now, it's like the age is almost the same, like 40 years and above. But we have seen, as I mentioned just now, the youngest one, I think, as far as I can remember, is 11 years old. So we have seen that young of age also. In terms of ethnicity, I mean, in the race in Malaysia, we have like the most common one is Malay, then we have Chinese, we have Indian, right? So the most common race will be Chinese, right?
Yeah.
And then followed by Malay, and then will be followed by Indian in terms of the race. However, having said that, we have like one state in Malaysia we call Sarawak, right? And then Sarawak, they have like few ethnicity, indigenous people there, ethnicity things. And among of them, like Bidayo is one of the ethnicity that they have like very high incidence of nasopharyngeal carcinoma. So that was even published in some of the journals and everything. So that's why nowadays we because of the high incidence of nasopharyngeal carcinoma in Malaysia, we have come up with some even CPGs so that people in the clinic kesihatan or the primary care center, general practitioners and everything, they have some guides on how to have the suspicion, because as I mentioned, nasopharyngeal carcinoma is something that as a generalist you have to have the suspicion. Only then you will be able to refer the patients to us, the ENT, then we can diagnose the patient. Right.
Yes, sir. Thank you for the insight. In Indonesia, what I've seen as well is the youngest patient in my hospital was I think it's 12 years old, same demographic, and usually it's 40 years of age. For in Indonesia, the ethnicity we is all ethnicity in Indonesia. There is no specific and no specific areas in Indonesia because I think there is a relation between the risk factor of eating preserved
So
food, yeah,
yep,
fish, yeah,
yeah, salted fish they said, yeah, nitrosamine.
yeah.
This is very common in Chinese population, they said. But I don't know, nowadays everything, everyone can access to every part of the world foods, right?
So the yes, so the Indonesia is all the ethnicity, not just the Chinese descendants in Indonesia. It's a little bit different.
Oh,
So the mortality
okay.
is yeah, it's quite high as you have mentioned in your PowerPoint.
Mhm.
Indonesia, yeah. Okay, thank you, Dr. Supaida, for answering my question. Anybody on this from the student have any question for Dr. Subaida or anybody in online that is attending? Okay, okay, okay. Or maybe Dr. Subaida has any question for the students?
How do you all think? Is it? I managed to cover. I want your input or your feedback. Maybe
Yeah. Okay. Okay. My for the feedback.
was it helpful?
Yeah, for me it's very helpful. I really like the way you reviewed the anatomy and the basic lectures. I think it will be very helpful for the students. Can anybody maybe give some feedback to Dr. Zubaida? Yeah, I think they're a little bit shy, Doctor.
Yeah, I understand. It's the same. My students also like that. Okay, right. It's okay.
They're a little bit shy. Yeah,
Yeah, okay, right.
I think if there is any feedback, they can personally tell me, and then we'll contact.
Okay.
Yeah, with the
Okay.
yes. Okay.
Sure.
Yeah. Okay. Thank you, Dr. Subaida, for this afternoon, for giving your time to teach us, and thank you. I hope that after this you have a nice day, Doctor.
Thank you so much, everyone. Take care. Bye-bye.
Bye bye. Thank you, Doctor. Ya, terima kasih semua ya, boleh live yang ada di Zoom. Mohon dipelajari untuk MCQ 2 baik yang IC maupun RC ya. Terima kasih.